Assalamu alaikum. Friends and colleagues, I hope you can hear me. I am speaking from Lahore. I am Professor Dr. Amber Malik, part of Pakistan Live 2022. Unfortunately, I could not be part of, I could not physically be present, and I am truly honored and delighted to be part of this great session for Go Red for Women. We have international speakers and we have our esteemed colleagues who will be panelists as well as chairpersons for this session. And we have three very interesting talks that will be conducted over the next 1 hour. All the women are here. We are the women of interventional cardiology, and I would like us to welcome all the women as well as the men who have always supported and brought interventional cardiology all together, both men and women, to the point at where we are. I would like to introduce my esteemed panel and chairpersons. First of all, I would like, because Go Red for Women is the American Heart Association. This is the Pakistan chapter for Go Red for Women, now presenting at Pakistan Live 2022. So this is a first such session being done in the past few years. I would like to now call Professor General Suhail Aziz, if he is present, to come and take the chair. Professor General Suhail Aziz, he does not require much introduction, I would say, but as he is one of our very well-known interventional cardiologists of Pakistan. He was the ex-commandant of AFIC and has been a very good lifelong friend and teacher to me as well. He is currently president of the Pakistan Cardiac Society, of which this chapter is presenting, and he's professor of cardiology and medicine at Fauji Foundation University. He's also ex-advisor cardiology of Pakistan Army and ex-dean of cardiovascular sciences of Army Medical College. Professor General Suhail Aziz, please come to the stage. I would like, is he there? Unfortunately, I cannot see the panel.
अंबर इंट्रोडक्शन हम उनसे करवाने जा रहे हैं डॉक्टर बिलाल मोहिउद्दीन से वो अभी पहुंचे नहीं
Okay, Bilal is here. I know
और
Bilal
डॉक्टर
is.
नईम असलम और डॉक्टर फिरोज मेमन को
Okay, हाँ मैं बुला लेती हूँ. So Professor Bilal Sheikh Bilal Mohyuddin, whom we've got down as Sheikhu because he's also been a lifelong friend and a great pioneer of interventional cardiology. He is currently the chief of Punjab Institute of Cardiology, one of the leading institutes in the country, and he is also the convener of. He has been a convener of many big meetings as well. So I would like to welcome Bilal Mohyuddin to the stage, and he will start off with the introduction. Let me just call the rest of the chairpersons if they are there. If they're not there, they can come and join later on. I would like to request Professor Firoz Memon to come up, who's also professor and head of department at Indus University, Hyderabad. Professor Firoz Memon, please come onto the stage. I would like to request Professor Khalda Sumro, who's the CEO and coordinator of the Go Red for Women Pakistan chapter and the leading light for all these sessions and a lot of academic involvement in Pakistan for women and their uplift. Particularly for women cardiologists. I would like to invite Professor Amber Ashraf, who, being my namesake, I have always looked upon as a friend and colleague. Professor Amber Ashraf. She is professor and head of cardiology department and director cath lab of Khyber Medical College, Khyber Teaching Hospital, Peshawar. She's also the regional coordinator for Go Red for Women of the Pakistan Cardiac Society and the AHA chapter for Pakistan. I would like to welcome Professor Haroon Babar Aziz, who is the previous head of president of Pakistan Cardiac Society and current head of department at King Edward Medical College and King Edward Medical University. I apologize because I studied from the college. I would like to call upon Professor Bashir Hanif, who, if he has time, out of all his activities in Pakistan Live, he has been the main course director and has really worked very, very hard for this meeting. He is also he's also the medical director an interventional cardiologist at Tabba Heart Institute, and is the leading light of Pakistan Live 2022. Harun Babar, I can see you come up, so please come up and take the stage as well. We have a few more names here. Dr. Sumaira Ahsan, who's associate professor, and she will be speaking for us, and head of department at Hamdard University. Dr. Faria Sadiq, I would like to invite onto the stage, who's consultant cardiologist and lead electrophysiologist at Tabba Heart, Karachi. I would like to invite I have one more panelist here, Professor Nadeem Hayat Malik, who is the previous, who has been the ex-director of Punjab Institute of Cardiologists. Again, one of the pioneers of interventional cardiology. His name needs no introduction. If he is here, please come onto the stage. And let me see if I have hopefully not missed anyone out from over here. Yes. And can I ask Dr. Saira Bukhari to come onto the stage as well? She's consultant cardiologist and head of cardiology services, Aga Khan Hospital, Karachi. Dr. Saira Bukhari. I hope you have enough chairs. Right. So now I would like Dr. Bilal Mohyuddin to start with the introduction, and then we will come on to the first speaker. Dr. Bilal Mohyuddin.
इंट्रोडक्शन आपने देना है
किधर है बुक किधर अस्सलाम वालेकुम जी. This GoRed initiative, which has been started off by the young ladies of Karachi, I would say, Khada Sumro is the youngest of them, and doing the marvelous job. The idea is that the issues about the women's health and the cardiac issues, which sort of interlink with each other, and then we have all observed the issues like pregnancy, etc., when ladies have these problems. These matters somehow or the other get eclipsed by the atherosclerotic diseases, and we sort of lose sight of what is happening. Unfortunately, this is something which is rampantly visible also in many other spheres of the academics. So this is an effort to start off this, and so far the GoRed has had an oncology session, cardiac oncology sessions, and 2 more sessions and cardio-obstetrics. So these were the ones which are sort of taking us forward. Now over here at the Interventional Cardiac Society's meeting, the GoRed is also visible. And in our subsequent meetings of the cardiology, which is basically the cardiology update, the Hypertension League, and again the annual cardiology cardiocon, these will be very important sessions and will be attended in a better way. But without much ado, I would like to invite the first speaker, who is...
Right. I will introduce the first speaker.
Rukhsana.
Yeah.
It's a recorded talk by Rukhsana Mehran. A lot of us are familiar with Professor Rukhsana Mehran. She's a lead cardiologist and a lead physician. And she has always stood up and has fought it out for not just the ladies, but for cardiology also. And without much ado, please start the presentation. Presentation, beta. इनकी आवाज़ नहीं आ रही बेटा, इसको रिवाइंड करो पीछे. लगता है तुम लोगों ने टेस्टिंग नहीं की पहले. रहने दिया करो यार. MP4 फॉर्मेट या KBC फॉर्मेट ਤੁਸੀਂ पहले टेस्ट करना सी. before they are able to fix up the glitches, may I please first ask Professor Saiba that, Professor Khalda Sumro, when you took off this whole idea, what was your main incentive or idea behind it?
For this topic, you want to say? For this topic, you say?
Go red. What was the concept behind the go red? Why did you feel? And none of you wear the beautiful skirt that is visible on the go red. I'm dying to see you all in those go red skirts that you always propose.
Red color is for the love. This shows, this gives us message that you must take care of your heart. You must love your heart. So that is especially this is given to message given to the women that you must take care of your heart.
So we say that man's heart is a woman and a woman's heart is a man. So in other words, you're accepting the fact that the women should take care of their men because even that is most important. Oh yaar, teri awaaz hi nikli baar.
Dr. Bilal, let us remove too much gender conversation out of this, shall we?
I'm just waiting for them to fix up the audio over there.
I think what we can do is that if they cannot fix it, we can move on to the next talk, and then and while they fix that. Why don't we do that?
PowerPoint आई है तो उसकी ऑडियो भी है इसके साथ। तो आपने मैडम को बताया था तो उसकी ऑडियो प्ले होती थी तो फिर बताया था। Okay, while we are fixing up the glitches, may I request Dr. Saraglai to kindly come up. Sorry for taking the name wrongly.
Saira
Bukhari,
Bukhari.
kindly to come up.
She is going to talk on percutaneous coronary interventions in women. Should management be different? So I think we look forward to Saira Bukhari's talk. She's an excellent speaker, Dr. Saira Bukhari.
Assalamu alaikum. Could you project my slides, please? So before I begin, Assalamu alaikum. Thank you for being here. I understand that a lot of people are sacrificing their lunchtime to be here to support Go Red for Women. And to borrow Dr. Roxana Mehran's title, Small Numbers, Big Impact. So my topic is PCI in women, should management be different? So I have no relevant disclosures, but I have a confession to make. I'm not an interventional cardiologist, but I am a cardiologist, and I think all
one of the
aspects...
disclosures is that your slides are not on for some reason. Thank God.
I realize that. Thank you. So, so the important thing is that PCI is a very common tool to be used in cardiology, and we should all be aware of how to use it, especially for 50% of the population. आगे कर लें, नेक्स्ट कर दें। अब आप चला लें इसको। आप वहाँ से कर लें। Okay. So nothing to disclose. You have my confession already. Okay. So let me start with a true story. An 80-year-old gentleman came to the ER with inferior posterolateral STEMI and got intubated in the ER. So he was rushed to the cath lab, and I was the primary cardiologist. I went outside after the angiogram to inform the family of the situation, and I thought that the patient's wife looked a little unwell. So the family informed me that she was not feeling well, so they would take her to the ER as well, while we were doing the primary PCI on the husband. So while we were going through the primary PCI, 30 minutes into the primary PCI, I got a call from the ER to inform me that the patient's wife was also suffering from STEMI, had been to the same hospitals where the husband had been, had complained of ghabrahat and insisted on a cardiac checkup. And she had done that twice. While her husband had been rushed to a cath lab, she was ignored, she was misdiagnosed, and finally, 30 minutes into the primary PCI of her husband, we came to realize that she also needed a primary PCI. So this is the dilemma that women face. So the roadmap for this presentation is I'll start with the Yentl syndrome, then and now, differences in presentation, in pathophysiology, in outcome, and in management, and the way forward. So what is the Yentl syndrome? Yentl syndrome is a deadly data bias against women. This is based on a film in 1983 in which Barbara Streisand played a woman who wanted to receive an education, and for that she had to disguise herself as a man. So in cardiology, the Yentl syndrome basically means that women are ignored unless they behave exactly like men. If they present like men, they are going to be treated, and if not, it could prove fatal. This was first brought up in 1991 in an editorial by Dr. Bernardine, and we will follow its course during history. So despite major advances in therapies, cardiovascular disease remains the #1 killer of women all around the world. And differences in presentation, treatment, and outcomes continue to happen, and it is flummoxed further by the fact that women are underrepresented in trials. So we all know that women present with different symptoms. I would use the word different, not atypical. If symptoms occur in 50% on your population, they would be typical for that population. So I would say symptoms typical for women, and this is what we must educate ourselves about. Women are known to have a different pathophysiology for their MIs as well. Less often than plaque rupture, they have plaque erosion, and also spontaneous coronary artery dissections are known to happen mostly in women, especially perimenopausal women and pregnant women as well. So in most trials of outcomes of PCI in men and women, whether for stable angina or acute coronary syndromes, women were generally older, they had more comorbids, they had more cardiovascular risk factors, but paradoxically, they were less often treated invasively for diagnosis and management, and their subsequent outcomes were poorer. And this was seen in all trials, all studies, and seen temporally as well. Basically, we are not improving with time. So this slide represents the ischemia time. It is known that ischemia time in women is significantly higher compared to men, and we all know that ischemia time is related with outcomes. So in-hospital mortality is also higher in women, and multiple studies have shown this. So what differences in management are seen? So women are less likely to proceed to angiogram for stable angina. They are less likely to proceed to PCI and CABG even after the angiogram. They are less likely to receive GDMT, and I will shock you all by saying that they are less likely to receive dual antiplatelet therapy, beta blockers, ACE inhibitors, and ARBs, and statins as well. So many of the drugs which are considered to improve the quality, the morbidity and mortality are less prescribed in women. They are also less likely to proceed to timely primary PCI and less likely to proceed to timely coronary angiogram in a non-ST elevation MI setting. So what about when they actually undergo PCI? So for complex PCI, women may have worse long-term outcomes compared to simple PCI. So maybe CABG would be a better management option for women who are thrust into complex PCI. With regards to stents, bare metal stents are known to work less well in women because they have smaller arteries and may have more diffuse disease. So newer deaths, especially newer generation deaths, have a significantly lower 3-year risk of MACE, less target lesion revascularization, and less definite or probable stent thrombosis as well. So newer generation deaths are the way to go. As far as vascular complications are concerned, women are more likely to have peri-procedural bleeding, vascular complications, retroperitoneal hemorrhage, as well as other complications such as contrast-induced nephropathy, GI bleed, infection, and death. The issue of vascular complications can be overcome by using a transradial approach for female interventions. And of course, these transradial approaches preferred both for men and women. But in women, there is an incremental benefit, and so this should be preferred, even though we know that the crossover rate to femoral is higher in the female. But the first option should be transradial as much as possible. A quick word about left main stenting. Women are more likely than men to have disease at the ostium of the left main, which is obviously very tempting to stent. But they also have, once they receive PCI for it, they are most likely to need repeat revascularization. This is basic. One reason for this is that they have smaller left mains. The mean left main diameter was 3.9 compared to 4.5 in men. Post-PCI considerations and other considerations include more common vasovagal after post-procedure, vascular access complications, clopidogrel resistance. Women have numerically higher platelet counts, and they also have more platelet reactivity after receiving a loading dose of clopidogrel. So it should be considered in your female patients whether they should receive other antiplatelets instead of clopidogrel. Instant restenosis, female gender, is an independent risk predictor for ISR. Also, the use of other imaging, including intracoronary imaging such as OCT and IVUS. When you see a patient who comes in with an MI, and before you label it as Minoka, you might want to check for spontaneous coronary artery dissection. Other imaging techniques include CT perfusion, cardiac MRI with perfusion, and PET scan to assess for microvascular disease and obstruction. So finally, we come back to the Yentl syndrome. In 1991, it was brought up. In 2011, it was revisited, and it was declared that the Yentl syndrome is alive and well. In 2015, in the developed world, there was a thought that if we use newer technologies and we use them more judiciously and improved our surveillance and medical care, then women could do better as well as men. So finally, in 2022, I ask you and I request all of you to consider women as, and whenever you are treating them, to be cognizant of these subtle differences and make an effort to use guideline-directed medical therapies in them. Thank you.
A review, and I really like the idea that a non-interventional cardiologist is commenting on this, because if you had given me this talk to do, I would have brought up differences between men and women, showed you techniques, this and that. But you actually brought up some very important points. And I think you really brought up an excellent example in the beginning of a husband undergoing primary PCI and the third presentation of the wife. I think that is really, really important to highlight, that this is what does happen to women. And I love the Yentl syndrome. It exists very much so. And I think there is only 30% representation of women in all trials and whatever. I do not believe that that is the extent of the disease. The disease is far more than it is ever represented in real life as well as in and I think as interventional cardiologists, as cardiology women, also, I think we also suffer from the Yentl syndrome.
Thank you so much.
Shall we take questions now? Or would you like to?
Let us take questions at the end. We're running short of time.
All right. Okay.
So
all right. Let's take questions at the end. But excellent presentation. So next presentation is, let me introduce the next speaker. She is Mirwat Alasang, and she's from Saudi Arabia. Alasnag, and she is from Saudi Arabia. She should be online. We have presenting outcomes, comparison of long-term outcomes in men versus women undergoing PCI. She is Director Cath Lab at King Fahd Armed Forces Hospital, Jeddah, Saudi Arabia. She was the first female interventional cardiologist in the Gulf region. She is currently the chair of the International Working Group of the ACC Women in Cardiology Committee, member of the SCI Board of Trustees and ACC Interventional Leadership Council. She's also the chair of Interventional Cardiology Working Group of the Telecardiology section of the International Society for Telemedicine and E-Health. So Mirwat comes with a big at her back, and she has worked very hard to be where she is. Mirwat, let us have your presentation. And she has been part of the Go Red for quite a while.
Well, thank you, Dr. Malik, and thank you to the Pakistan Cardiac Society for this invitation. And this is a fantastic initiative that I'm just honored and privileged to be part of. You know, a lot of my presentation as an interventional cardiologist is going to be repetitive. You've heard a little bit of it from the previous speaker. And I think the reason is that we all need to take pause. I think it's very difficult when you look at the data to extract meaningful conclusions because of the poor enrollment of women. So when Neil Armstrong landed on the moon, he said, "One small step for man, one great leap for mankind." But when we look at examining women, I think many people think it's just, oh, women are just, whining and complaining again and not enough enrollment, etc. But let's look at the field of science, the field of interventional cardiology and what happened to it when we started addressing women a little more specifically. Many years ago, for example, MINOCA. Many years ago, we did not address myocardial infarctions with non-obstructive coronary artery disease. We would just brush them off and send these patients home. Because we were seeing a higher incidence of MINOCA in women, we started to explore it a little bit more. And we started to understand that it's really an umbrella of diagnoses, and it's not just one diagnosis. So we're looking at SCAD, we're looking at Takotsubo, we're looking at myocarditis, etc. Diseases which affect men as well. So really, as we're examining women, we're learning more about the science, and we're learning how to treat all our patients, irrespective of the gender. So despite a lot of the well-known gender dimorphism, that there are differences in terms of atherosclerosis, in terms of biological outcomes, etc., we still don't know a whole lot. And in multiple histologic and imaging studies, whether you're looking at intravascular ultrasound, whether you're looking at CT, etc., the overall plaque burden and markers of inflammation seem to be greater in men compared with women, and generally predictive of cardiovascular events. And young women are relatively protected from cardiovascular disease. By the 7th decade, however, the incidence of MI in women surpasses that of men, suggesting that there's an interaction between gender and age, something that preclinical studies in animals, we have seen, but we really didn't explore it more in clinical grounds, and we really don't have enough well-powered studies that can inform us a little bit more about that. And so when we look at men and women and the differences, we have to look at, yes, there are lifestyle differences that we all know about. There are healthcare issues and biases that we know, whether it is in research, whether it is in the healthcare system, etc. There are also environmental differences that impact us, and there are cultural attitudes, financial resources, education, etc., that impact our women as well. And what does that all translate into? It translates into a different pathology. You're looking at plaque erosion versus plaque rupture, you're looking at SCAD, you're looking at all of these. And so let's look at it a little bit more. When we're looking at risk assessment, women with an acute coronary syndrome take approximately 13 to 36% more time to present to a hospital. And women, especially young women, non-white women, underestimate their risk of heart disease. Healthcare workers also tend to underestimate the risk of women that are presenting to them. And from the variation in recovery, the Virgo trial found that 53% of women reported that their provider didn't think that these symptoms were cardiac in comparison with 37% of men. And why am I emphasizing this? Because it certainly makes a difference. So when you look at 2009 to 2019, that is approximately a decade. What you do see is, yes, there has been a reduction in the incidence of heart attacks and heart disease, with a rise in breast cancer and cancers overall. Nevertheless, you're still seeing fewer women diagnosed and managed appropriately when it comes to cardiac diseases. Again, looking at the presentation of these women in Virgo trial, which looked at younger women with ACS taking about 48 minutes, that is 30% longer to present during an acute MI compared with men of the same age. Median time from symptom onset to hospital presentation in women was 3.2 hours compared with 2.4 hours to men. And we all know the door to balloon time makes a huge difference. And you see it across the board. So when you're looking at Australia, for example, this is a very large study that looked at over 13,000 patients with acute coronary syndrome, again, showed a significant delay in women compared with men. When you look at this Symposium study group that was done in Sweden, again, it was showed the same thing. The Korean National Registry showed the same thing, and then the Arabian Gulf Registry. So I've just went through all of these across the board, and it isn't unique to one part of the world. It isn't just Asians, it isn't just Australians, it's across the board. And unfortunately, we do know the door-to-balloon times do impact outcomes in these patients. And this is what you see in the bottom screen is from the Virgo trial, and in the top graphs, what you see within 60 minutes and over 60 minutes, you clearly see women in pink have higher times compared with men. And this is from the Middle East group or the Gulf group. Again, when you're starting to look at age, when they broke it down by age, you see that women tend to have higher compared with men revascularization and higher, hence, in-hospital mortality, let alone the one-year mortality. And when it comes to diagnosis, again, this was presented at ESC. Actually, they looked at over 41,000 patients, 42% were women. 41% of these women compared with men had a delay of over 12 hours in terms of presentation and management. And probable ACS was noted in 39% of women compared with 44.5% of men. Again, the reason I keep hounding on this is that ultimately it impacts how you manage these patients, and how you timely manage these patients impacts outcomes. 5% of ACS were initially misdiagnosed in women compared with 3% in men in this large registry, and it was statistically significant. When we look at treatment, again, women with ACS are less likely to receive reperfusion therapy, be referred for angiography, and then even when they get angiography, less likely to be treated with PCI. So again, when we look at this, was published in Circulation only a couple of years ago in 2020, what you do see here is that those with ST elevation myocardial infarctions, as well as all the therapies that can be presented in these patients with arrhythmias, shockable rhythms. Again, when you compare women compared with men, it was certainly fewer women got the targeted therapy, fewer women got shocks, mechanical support, etc. And again, looking at the delays. So when you're looking at time from first medical contact, you look at time from first EKG and so on. And even when you break it into brackets across the board, women, it was statistically significant. If I go back here, you see a p-value of less than 0.001, and you're looking at presentation less than 12 hours, more than 12 hours, etc. These impact outcomes, unfortunately. Again, this is from a British publication, women with a high GRACE score. We all know that a lot of the data suggests that as the GRACE score goes up, patients tend to benefit from revascularization more and primary and PCIs. Unfortunately, these patients with acute coronary syndromes and non-STEMI who present with a GRACE score of more than 140, 50% are less likely to be referred for cardiac catheterization within 24 hours. Although early revascularization has been proven in multiple studies at this point in time, and you can see that it is across the board, especially in those with a high-risk score. Timely reperfusion, again, I'm harping on the same thing. This is a wonderful publication by Wilkinson and his group. 76% of women compared with men had timely reperfusion therapy, whether it is by lytic therapy or whether it is by primary PCI. In all cases, it does impact your overall outcomes, and you can see here the Kaplan-Meier curves over 30 days in the survival by sex. Women certainly have a lower survival, significant p-value, and as you continue across time, you do see a further reduction of that. And let's look at younger women. So when you're looking at morbidity, they tend to have higher morbidity, lower acuity of the illness, lower use of coronary angio and PCI, and higher in-hospital mortality. And you see all of that here. And unfortunately, over time, what we're seeing, if you see from 2000 to 2017, these Kaplan-Meier curves are actually separating further and not actually improving, sadly, particularly those who have cardiogenic shock. This was a meta-analysis where they showed over 1 million patients, the odds of in-hospital mortality, 30-day mortality, 1-year mortality, and 2-year mortality in women compared with men to be higher. Again, you can see it over here in the forest graphs. And when you look at women who, and this is, and again, another elegant publication that looked at PCI and outcomes over 5 years. Women had smaller reference vessel diameters, shorter lesions by angiography that was core lab adjudicated. At 5 years, women tended to have a high major adverse cardiac events. All-cause death was higher. Ischemia-driven target lesion revascularization was also higher. And even when you do adjust for differences in terms of clinical presentation, lesion characteristics, and so on, female sex was an independent predictor of major adverse cardiovascular events in this trial. And so men tended to do better. This was yet another publication looking at, it's the Chinese chronic and acute coronary syndrome project that really tried to capture outcomes across the board and was published approximately 2-3 years ago. Once again, when you look across the board for all curves, all-cause mortality, you do see a definite big difference between men and women that continues on and persists across time, whether it's time from hospitalization to days as you're looking across, and whether you're looking at STEMI, non-STEMI, etc. And again, when you're looking at medications, and the previous speaker already referenced that when you're looking at anticoagulation, antiplatelet, beta blockers, all the medications that we really should be putting our patients on, this is a different publication from the European Society of Cardiology that actually did show there were significant differences even when you divide it by age in these patients. And what do we know about medications? My colleagues and I looked at this and looked at the cornerstone of medical therapy for PCI, patients undergoing PCI, ACS, and so on. And there's a host of these medications. When you look at Oasis 7, for example, and Gravitas, both of them over a decade old, what we do know from Oasis 7 is that there's really no overall difference in double dosing with clopidogrel as opposed to single antiplatelet therapy, but in Gravitas, and we didn't see a big difference in women. Nevertheless, in Gravitas, what was suggested here is that we did see a difference in women. But then look at here in pink, the enrollment of women, 27%, 35%, 27, 21 across the board, stopped DAPT, more recent trials, host exam, etc. So the enrollment is very low of women in these trials. Even when you see conflating outcomes in these different trials, should we be double dosing in accordance with Gravitas or not double dosing in accordance with Oasis 7? In women in particular, we don't really know, because the results were conflicting. These were not pre-specified outcomes, and you really can't make any meaningful or tangible conclusions from them. And then finally, moving on to other more important things that or procedural techniques that impact outcomes as well. Radial access, interestingly, the effect size for the reduction in hospital major bleeding associated with radial access in women is greater than that for men, suggesting that women may have a greater benefit for this kind of an endpoint, and perhaps women should be getting more radial access. Nevertheless, across the board and across regions, a lot of the data suggests that women are less likely to get radial access because of the myth that women have smaller radial arteries, which isn't necessarily true. They can accommodate the current radial sheaths. Again, intracoronary imaging, even after differences in baseline characteristics, female sex was an independent negative predictor for undergoing intracoronary imaging during a given PCI. Again, there's data from the ultimate trial, etc., that have shown improved outcomes when we use intracoronary imaging for our patients. And even when we're looking at MINOCA, it's now recommended that you do intracoronary imaging for patients with MINOCA. We do know that women are more likely than men to have MINOCA, and yet fewer women end up getting intracoronary imaging. Complete revascularization. Several trials, such as the COMPLETE trial, etc., have suggested that complete revascularization improves outcomes in patients presenting with acute coronary syndromes. Women tend to have a higher residual risk, what we call a residual syntax score, because they have incomplete revascularization. And that is directly linked with poor outcomes in terms of higher rates of cardiac death, myocardial infarctions, and so on. And again, even when you adjust for risks and comorbidities, we're still seeing that. So, this is one of our patients who had a non-ST elevation myocardial infarction. Coronary angiography showed normal coronary arteries, and MRI confirmed, as you can see over here, full thickness myocardial infarction, suggesting that we need to investigate this patient further. Sadly, even in my laboratory, we hadn't done intracoronary imaging for this patient. Did she embolize? Did she have a plaque erosion? Did she, and this is what we need to be doing, treating these patients more aggressively and looking outside the box. So I'm going to stop over here, and again, thank you for the invitation if you have any other questions.
Thank you for being with us in Pakistan, Mirvat. We see you often at PCRs and various places, and it is really very, very nice to see you presenting here. I have a few questions, but if they want to take on Roxana Mehran's presentation first, and then we can come back to you. So stay with us. Do we know that the presentation is ready for presenting?
There's a bit of an issue with its audio, so we're just checking it out if it works.
So why don't we ask a question and answers?
Yeah, I think we should.
इसकी आवाज़ ऊंची करो जरा. I'm afraid this.
It's ready.
Here we go.
But with regard to this presentation, I'm the founder of Women's One, and I'm going to talk a lot about that. It's a not-for-profit organization. Don't think that women have not been in cardiology. We've been there for a long time. Maud Abbott in 1930 inventing a conventional classification system of congenital heart disease. Dr. Myra Logan, the first woman to operate on a human heart. Dr. Ola Herring, the first female fellow of the American College of Cardiology, and I need not tell you about Dr. Johnson, who was the first president of the American Heart Association, who came up with our own corrected operation for patients with congenital heart disease. And of course, this just goes on and on. But if we have women in such fantastic places, what do we look like in numbers? Take a look at the numbers from 2017 all the way to 2020. The number of female physicians in the specialty of cardiology is quite small, only about 16%. These numbers are really, really pale in comparison to other amazing subspecialties that we've been able to attract. Why is that? Why so few women want to be cardiologists? And this is really what you're seeing. Over half of the medical students are women in the United States. 50% go into internal medicine, and only about 20% or so come into cardiology. And a lot of it has to do with these barriers. The barriers are clear in terms of occupational exposure, discrimination, harassment, family concerns, lack of advancement, and leadership opportunities, and disparities in compensation. All of the things you would imagine would never exist in 2022, but it's quite there. And it's repelling women for wanting to become cardiologists, which is very, very upsetting to me. In fact, if you look at the rates of discrimination between men and women, you see it's a lot worse for women. And over time, it has not improved. That still there is sexual and racial differences in receiving discrimination in the workplace. One of the biggest things that we see is family planning considerations, which is very, very important and need to happen before and during and after pregnancy. It's very, very important to be able to continue to have that very, very important considerations for cardiologists. This particular study gives a very, very nice outcome. It's also important to note that women together are stronger, and we're seeing that strength in women being played out in terms of reach, benefit, and of course, empowerment of women. There are so many different ways that we are able to work together, just a raft of others, all of us together working to empower one another. And I started this a very long time ago, almost 20 years ago, thinking about Skywin, coming up with Women in Innovation with Ale de Kepa, who's now the president-elect of the European Association of PCI, which is tremendous honor to the two of us came up with this idea of dealing with the gender-based issues in interventional cardiology and trying to create and foster professional development, education, and collaboration and reach by and behalf of women in interventional cardiology. Our European colleagues took this right on and lobbied for better representation of women in interventional cardiology and have really done a fantastic, tremendous job. But I co-founded Women as One with my colleague and dear friend, Professor Marie-Claude Maurice from France. Our idea was that we need to have a unified mission to promote talent in medicine by offering women physicians unique professional opportunities, and that by doing this, we aim to build a more inclusive, diverse, and just workplace medicine. We're shifting the narrative of women in medicine, and our approach is to amplify women by aiming to highlight the work and voices of women in medicine and promoting their individual talents and advocating for their collective interests. We fortify through educational and awards programs. These are really, really fantastic. They're allowing hundreds of women physicians around the world, giving them funding and allowing them to succeed and to be mentored and to have a broader professional network. And we're unifying the houses of cardiology by bringing healthcare organizations in their quest for diversity. And we're doing this very, very well with our colleagues in the multitude of professional societies. If you look at our work, our talent directory is close to 2,000 women with a fantastic professional network. It's a global data source with exclusive opportunities. We have programs that will allow women to climb the ladder of success with Climb Research, Climb PVD, Climb Pulmonary Response Team, so many programs, Climb Endovascular. We also have Escalator Awards and, of course, our RISE program. We're working very, very hard on equity in action with our work on radiation safety, parental leave, and professional advancement. I talked to you about the talent directory. It's close to 2,000 women now. We are able to tap into this talent directory with all of these women, with their CVs, understanding what kind of opportunities are available for them and what kind of talent do they have that can be leveraged to those opportunities. As you can see, it's a global directory all over the world, so many countries represented, and with several different subspecialties within cardiology. Our impact is huge. We have tremendous amount of case-based learning opportunities, and we've been able to already award over $850,000 in our Escalator Award program. We're doing a lot of work. We've only just begun. We can't wait for our RISE program during February of 2023. And our only way forward is
panel discussion and any questions, please.
The
Actually, with your permission, Dr. Dara, I just want to make one comment that a decade ago, I was selected by a male mentor. I respect him a lot, but for my strength, he told me my strengths. But now the women role are just stick to the board red forum. Why in 4 days I haven't seen a woman representation from any geographical world, not from Pakistan, not from Turkey, not from Britain, from anywhere. And now with NICV and all these things, people and Kaba and this question I should ask Dr. Vishnu to leave, that we were selected by the male mentors, but our roles are just stick to the board for women.
शीर साहब स्टेज पे आ जाए मेरे पास.
स्टेज पे नहीं जाना है मुझे, दूसरे रूम में.
Gentle syndrome.
Let me.
And why their role is just stick to the board and for last 3 days, I haven't seen
Okay.
any woman
Okay.
presentation in
So it's the
that.
same. Let me answer the question. First of all, it was interventional cardiology session, and there are, there are limited females. But I can tell you, I invited 2 women from Turkey. Both of them agreed, and the last minute they said they couldn't come. I had requested Dr. Mirvat Al-Asnang also. Amber was supposed to be here, she couldn't come. And from Karachi, otherwise there is no interventional female as such who is basically doing the interventions who has not been invited. So I think whoever was available, we tried our best, but unfortunately they couldn't come. I called Amber so many times, she couldn't come. So it's not that we didn't invite women.
To save you, Bashir Ali sir.
And sorry, one second. In
Bashir,
fellows course as well as in nursing symposium, a lot of women gave the talks. There are women sitting here who had presented the cases in several sessions, and even for next 2 days or today also, there are a lot of women who will be presenting cases. So that's not true.
And if I may add to that, it was a woman cardiologist. And Bashir sir, if I may add to it, it was a woman interventional cardiologist who did the ceremony yesterday of the...
Exactly.
And she's in the Fatma as well as the interventional cardiologist.
Can I interfere here and say, Bashir, it is really nice to be here. I am one of the course directors. There are 3 course directors. One of them is a woman. So do not worry about it. We are getting there. And I think let's
I think Professor Amber is saying something, we can't hear her.
Also a concern with Dr.
We can't hear you, Amber. There's
Bashir
an audio issue going on.
We will have to, if you don't mind, please, because our next session is getting delayed.
So
if
I
there's
will,
nothing else left.
with
Obviously, it's an excellent
with
debate.
due
and
respect
needs
of
to be
everyone.
probably a separate debate.
Just few lines to it.
Okay,
One-
just
one-
add.
One thing which has been missed is that it has been reported in several papers that women only respond to acetylsalicylic acid. Aspirin, which is the drug of choice for ACS or for ischemic heart disease. So we have to find an alternative, number one. Number two, especially it has been seen that women of lower socioeconomic background, they have a higher rate of ischemic heart disease, more than 25% deaths with ischemic heart disease as compared to men. So these should be taken into account.
And just to end the whole thing, before I give the mic, because I have to rush out, that's why Bashir Ali is sitting over here to get me. I'll just simply say one thing. The reason why women are declined healthcare is because of women themselves. Please notice this statement very clearly. It is the mother who says that don't disturb the son to take me to the hospital at night. While when it comes to the father, she says, take him right now. It is the women who undermine their rights, not just in the heart, also in other health matters and in their social issues. So it is the need for us, like what Professor Khalda Simro is doing these days, arranging these massive lectures, going out over there to the colleges and everything, everywhere, that this needs to be done. The Yentl syndrome that is being talked about is a syndrome created by a woman, for a woman, to the woman. So let's try and get out of it. Thank you. And I will beg leave.
Bilal, we will have this conversation on another forum. Dr. Halda, can you wind up? Can you give us a vote of thanks? Because I think Mirvat is also waiting for some questions and answers.
Thank you so much
but
for with us during this session. I think this was a very important session for our women cardiologists. We can see that these women cardiologists 10 years ago, we haven't seen any interventional cardiologists in Pakistan. But nowadays, by virtue of the services of NICVD, we are slowly and gradually having increased number of the interventional cardiologists who are working in the peripheries, where the services were not established and women were less likely went into the interventions of coronary angiography and angioplasties. I know I was the first lady cardiologist, interventional cardiologist who established two cath lab. Dr. Nawaz Lashari is witnessed. We worked a lot over there, and single woman was running the cath lab over there. So you cannot say that in Karachi there is no interventional cardiologist over there. You must encourage our lady cardiologists to come forward and speak on these international forums. If we won't give them opportunity, they cannot be.
All your points are very well taken, and inshallah in future we will take care of it.
I just want to make one comment. Thank you very much for this very informative session and the talks. Important thing is the cardiovascular diseases in women is something which is neglected, and the main important issue behind this session is awareness among the doctors, among the general community and the things. So my request is these type of the sessions should be conducted in collaboration with all the male cardiologists, because most of the females are being treated, more than 95% of the females being treated by the male cardiologists. So these lectures should be in joint version. It should not be a just isolated session. Dr. Bashir Hanif, this is my humble suggestion.
I think I really appreciate it, and thank you very much for everyone's comments. We have to end it. One of the major things for Pakistan Live is we don't even go 1 minute ahead, and it's like 20 minutes more. So I'm sorry, but we have to stop now.
Sir,
thank you so much.
Session's 30 minutes.
That's not my fault. That's not my fault. That was your. So I apologize. I really apologize.
Workshops were going on, and
I
that's
know.
why it's delayed 30 minutes.
I'm sorry. I'm sorry.
Thank you.
Sir, please, this is a long debate. Please, I really request you. Thank you so much.
Okay, thank you very much. Thank you.